Right, so I think are we started? Are we fantastic? Great. Thank you so much, everybody, for joining us. Apologies for some of the technical difficulties at the beginning. It's 2026, but we're still having issues with Zoom. But it's my great pleasure to welcome you all to this cross NIHR collaboration for multiple long-term conditions methodologies workstream webinar. Where we're going to be looking at patient-reported outcomes for multiple long-term conditions. What, why, and how. Um, and I'm delighted to introduce Dr. Sarah Hughes. Sarah Hughes is a researcher at the Centre for Patient-Reported Outcome Research at the University of Birmingham. Her work focuses on how health outcomes are measured, with an emphasis on capturing people's real-life experiences of living with long-term and complex conditions. Her research interests are shaped by over 2 decades of clinical practice as an NHS speech and language therapist, where she saw firsthand how important person-centred outcomes are for guiding care and supporting shared decision-making. So I'm delighted to introduce Sarah, who's going to speak for about 25 to 30 minutes, and then we'll have plenty of time for a Q&A after that. So over to you, Sarah.
Thanks very much, Rose, and good afternoon, everyone. I'm delighted to be here to talk about patient-reported outcomes. So thank you very much for joining the webinar, and I hope we have lots of time for discussion following this presentation. So in terms of what I'd like to cover today is to start, I know there's probably a lot of expertise on the call today, but just so we're all on the same page, a little bit of background to multiple long-term conditions, or MLTC. What are patient-reported outcomes, or PROs or PROs, and what are patient-reported outcome measures, PROMs? Why do PROs measure or matter for MLTC? And what are some of the key challenges for measuring PROs for MLTC, and how can these possibly be addressed? And then I'm going to just present a case study showing how we've tried to think about and address some of these challenges in the context of developing the symptom burden questionnaire as a measure of symptom burden specifically for MLTC. And then just to wrap up, just to summarize what we've discussed today and to highlight some future directions for discussion and research. So, multiple long-term conditions, the coexistence of 2 or more conditions within a single person, is a growing health challenge. We all know this. It's been described as an urgent global health priority because prevalence is growing. Prevalence is high. And we know, for instance, in England, that 1 in 4 people are currently living with multiple long-term conditions, and that this increases with age, with up over 50% of people age 65 plus living with MLTC. And prevalence is going to only increase over time. And certainly studies have looked at modeling and projecting into the future about what that might look like. And we know that by 2049, that the number of people in the UK and England living with MLTC is set to increase to over 30 million. And importantly, we need to think about MLTC as quite unique, as having distinct clinical characteristics. So it's not just a case of someone living with 2 diseases or 3 diseases or 3 conditions. It's more than 1 plus 1 does not necessarily equal 2. It is more than the sum of diseases because of the interaction of these conditions. And as such, MLTC can have quite a significant impact, not only on people who are living with MLTC, but also the services and professionals who are helping to care for them. So MLTC has complex interactions across conditions. Oftentimes there are competing treatment regimens where people are having to take multiple medications, so polypharmacy, and often have lots of NHS appointments. So they're high healthcare utilization. So what does this mean? It means that people are juggling multiple symptoms, multiple treatments, and multiple appointments. And so to think about this and to encourage approaches to care that are responsive to MLTC, NICE, the National Institute for Health and Care Excellence, has recommended care that is joined up, that avoids unnecessary burden and supports quality of life. And so this is a holistic approach, it's a person-centered approach, and therefore that requires a focus on what matters most to the individual. But clinical measures. So when I talk about clinical measures, I mean things like tests and scans, things like blood pressure and blood tests. These measures alone may not tell the full story in terms of measuring what matters most to the person who's living with multiple long-term conditions. So, what's the solution? So, that would be patient-reported outcomes because these are especially designed to measure what is most important to a person about their health. So, what are PROs? So, if we look at the definition that you most often see in the research literature, which comes from the US Department of Food and Drug Administration, the FDA, PRO, a patient-reported outcome, is a measurement based on a report that comes directly from the individual about the status of their health without amendment or interpretation by a clinician or anyone else. So, what does that mean in practice? In practice, that means PROs capture aspects of health that only the person can report. It's only knowable to the individual. A clinician can't look at someone, for example, and say, you're in X amount of pain today, or you have this level of fatigue. So PROs actually focus on experiences that cannot be seen in tests or scans. And examples that are often mentioned are things like symptoms, treatment burden, or how demanding care is to live with, and quality of life. But within that, there are also a lot of other what we call latent constructs or self-reported concepts that align themselves well for measurement using patient-reported outcomes, and things that we know increasingly within MLTC that are important to individuals, especially things like participation, loneliness, treatment adherence. So anything that we can't measure with a clinical test that only known by the person is what we use, which is suitable for use by a PRO. So what's the difference between PROs and PROMs? So PROs or PROs or patient-reported outcomes is what we're trying to measure. It's what matters to people about their health. And as I just said, these can be things like symptoms, treatment burden, and quality of life. And PROs are measured using PROMs. PROMs are the tools that we measure PROs with. And typically these are structured questionnaires, not informal surveys. So these are, although they look simple on the outset, they're not the same as a customer satisfaction questionnaire you might be asked to complete after buying something online, for instance. They're actually scientific instruments that are developed using well-established, regulatory endorsed methods. So from the FDA's patient-focused drug development series, for example, ACE-POR, and also international best practice consortia, organizations such as COSMIN, which recommend the best approaches and methodologies to develop these measures. So why should we use PROMs? So these are not necessarily specific to MLTC, but it's useful to think about how in practice PROMs can support research and care. So first and foremost, there's good evidence out there to show that PROMs can support and improve patient-clinician communication. There's research to show that when a PROM is used in a clinical consultation, that patients feel more empowered to raise issues of concern about matters of importance to them, more so than in a traditional consultant-led consultation, for example. PROMs can facilitate patient engagement through self-monitoring of their health, can support also then their self-management of their health. There's good evidence out there to show that PROMs can support health services with triage and clinical management, for example, to reduce unnecessary appointments. You can look to Denmark for evidence of this. The Ambiflex system, which is used in outpatient care, finds patients completing a PROM before they attend for review. Those PROMs are reviewed by the clinical team, and a triage system is used by which the PROM scores are used to either invite a patient back to clinic, to have a telephone review, or if the scores are showing there's no change or they're within an acceptable range, that no action is necessary. And using prompts in this way has been shown to reduce unnecessary appointments by up to 50%. And of course, when we talk to our patient partners who talk about the realities of managing MLTC, who say they have multiple appointments, that they have to explain their symptoms and give their history to different clinical teams, they've strongly have recommended that proms could support that by having a single prom that can be accessed via the electronic health record, visible to different teams, might help to reduce burden in terms of having patients to reconfirm their condition and report their symptoms across different groups and different services. And also, proms have been shown to improve patient outcomes, importantly, to improve the identification of serious side effects and disease progression. And we can look to research in cancer for this, where there's been a randomized control trial looking at patient-reported outcomes that were completed remotely by patients during chemotherapy compared to standard of care. And they found that those patients that reported their symptoms using proms actually had fewer A&E attendances, fewer hospital admissions, improved outcomes, and improved overall survival. And then lastly, but not least, if we think about the use of proms as a research tool, they can be used to evaluate treatments from the patient perspective. So gaining insights into the impact of a new therapy or new intervention on health, impacts on treatment burden, and on quality of life. So just want to spend briefly in talking about how do you actually develop a prom. So, as I said, the methodology around prom development is really well established. And it's best viewed as a cycle because actually you never really stop developing a prom because our knowledge about health conditions is changing. We're constantly trying to add evidence to the evidence base about a prom's measurement characteristics and its implementation. So it's very much a cyclical and an ongoing process. But if we're starting to think about a new prom to measure a new construct, so thinking about something like symptom burden or quality of life, it's really about figuring out first, what are we actually measuring? And the recommended guidance is very strong in stating that this needs to come from people with lived experience. So typically we will have qualitative studies, interviews, focus groups to gather that information to get those first-hand accounts of what it's like to live with a particular health condition. That will be supplemented by literature reviews and expert reviews, but certainly the primacy is given to lived experience. And that goes throughout the cycle. It's very much a process of having that lived experience perspective front and center. So after we've defined what we measure, we call it concept elicitation, we then look to develop the questions. We develop a pool of questions, and then we go on and we refine and we pilot test them. And again, this is with interviews, surveys, with people with lived experience, when we're asking questions like, are the questions easy to understand? Are they accessible? Are they relevant to your lived experience? Are they comprehensive? Are we missing anything? So it's a very much a period, a back and forth process, an iterative process where we refine and test and refine and test till we arrive at what we think is a fairly definitive prom that we then need to check to see if it works. And we typically do that again by field testing, but again with people with lived experience, inviting them to fill in the draft questionnaire. And this is usually quite a large number of people, so hundreds, even thousands of people. And then we collect their responses and we analyze them using statistical methods, so psychometrics, to establish the measurement properties for the prom, to establish, is it actually measuring what we want it to? So is it valid? And will it do this in a consistent way over time and across groups? So is it reliable? And once we have good evidence that it is reliable and it is valid, then that prom is ready to use in practice. And then we have ongoing improvements and we go around the cycle again. So just to illustrate that process from going from lived experience to actual prom question or what we call an item, these are excerpts from qualitative interviews that I did a few years ago before the pandemic to develop a prom for people with hearing loss about measuring the effort required to listen when you have a hearing loss. So, for example, we have hearing feels like you're extending, you're on the roof, all your antennas going. You've got hundreds of antennas, and they're all reaching out, reaching out, reaching out. And that, after iterative refinements, came down to being, in a typical week, to what extent do you strain to hear speech? And a second example, I cannot listen and do other things well. Whilst driving, I would not allow my wife to talk to me as the listening effort took my mind off driving. In a typical week, are you able to listen to someone talk while doing something else? So I hope that sort of shows you that process of trying to come from that first person account into a question that's accessible and measurable. But what does this mean for MLTC? So most proms, and we have thousands of proms out there, focus on either single conditions or general health. And these do not reflect the combined and interacting impacts of what it means to live with MLTC. And this is coupled with actual limited availability of MLTC specific proms relative to the vast number of single condition proms that are out there. But my next point, which I think speaks to the heart of PRO measurement in MLTC, is that people experience MLTC very differently. If you think about what might be important to someone living with diabetes and stroke versus someone who's living with depression and dementia, what's important to them could be very different. So how do you capture these different combinations and lived experiences within a single prom? And this is compounded by the fact that our existing guidance for prom developers was really not designed for this level of complexity, where we have multiple combinations of conditions within an overarching condition, which would be MLTC. So it's very much intended for single conditions where you're able to do that really in-depth qualitative work. And we also have barriers to uptake and use, but that's another topic in and of itself. So not for today's webinar, but happy to come back and talk to that one as well. So what are the opportunities? What helps address this issue of complexity and when we're thinking about PRO measurement for MLTC? Well, firstly, core outcome sets can help. So core outcome sets are a set of agreed outcomes that are usually developed through consensus involving a group of people sitting down and agreeing what outcomes matter. And these are usually people with lived experience, their carers, researchers, clinicians, other stakeholders, methodologists for PRO methodologists, for example. And core outcome sets can include PROs and they can also include clinical measures. But that helps us to sort of agree what is needed in terms of PRO measurement for MLTC. We need to recognize, another thing that would help is recognition that the single condition approaches to PRO measurement are not appropriate to MLTC. Administering a diabetes prom and a stroke prom might not capture that interaction of the two conditions within an individual. What else can help? Personalization. So there are proms, particularly proms developed using more modern measurement techniques that can support item selection so that they're more personalized towards the individual or a group of cluster of conditions. These are things like item banks. So item banks are a repository, a database of questions that have been validated and calibrated for measurement, and they can be used to select and build bespoke scales. They can also be used to do something called computer adaptive testing, where the question that's administered and the person's response then determines the next question that gets selected. And those can be quite advantageous if you're thinking about issues of burden to respondents. What do we need? We need more prompts that are designed specifically for MLTC from the outset. We also need inclusive prompts that are accessible and representative and meaningful for diverse populations. So not only thinking about the various condition combinations that might exist, but also recognizing that social determinants of health and health inequalities play a huge role in MLTC, and that often we need to really focus and develop our methods so that we can capture the voices of underserved and underrepresented groups, so their lived experiences are also included within our prompts. Otherwise, we are not creating prompts from the outset. The content will not be relevant. And we also need to innovate on our methods so that we have methods capable of addressing this complexity that is inherent in MLTC. And I think for the first time, we are getting close to having a way forward with this. So with the advent of AI, with the advent of large data sets, to innovate and develop our methods so that we have more of a toolbox available to us to really focus on capturing complexity and representativeness. So now I'd like to just illustrate some of these points using the symptom burden questionnaire. This is work that is currently ongoing at the University of Birmingham. The work I'm going to share with you today has been submitted for publication and is currently under review. So I'd be grateful if it's not shared too widely. So the symptom burden questionnaire for MLTC is a new prompt measuring symptom burden that's been developed specifically for multiple long-term conditions. So it's intended to be cross-cutting, to think about the person in a holistic sense, to measure symptoms and impact on daily life. It's holistic in the sense that rather being organized by condition or by diagnosis, it's organized by body system. So thinking about circulatory symptoms, breathing symptoms, digestive symptoms, rather than diabetes or stroke or eczema or hearing loss. And we've designed it to be flexible and modular, so it can be used across different MLTC combinations and in different care settings. So in this sense, it is an item bank, and it consists of standalone scales aligned to body system that can be either used on their own, so a single scale, or can be used in combination, or can be the whole SBQ can be used in its entirety. And we've adopted this approach based on work we undertook during the pandemic to develop a questionnaire looking at symptoms in long COVID, which at the time was a new emerging condition. We had no biomarkers or tests we could do to diagnose long COVID. The only thing we had was to go by symptoms. And these symptoms, there was a vast number of symptoms, over 200 symptoms. They crossed every body system, and they were hugely variable from individual to individual. So you can see the alignment of that presentation of long COVID got us thinking, could that approach also be applied to MLTC? Because MLTC means that people often experience multiple symptoms that cut across conditions that affect multiple body systems. And we also think that, and as I said before, that sharing information across different clinical specialties can be different, but having an overarching prompt that can be applied irrespective of condition could support that, could support patients in that way. So this is the diagram I showed you earlier about the process of prompt development. And what I'm going to share to you now is the first step that we did to figure out what to measure. So what we call concept elicitation. And as I said previously, typically we would want to, and we still do, involve people with lived experience to figure out all of the different symptoms that we need to measure. But because of the complexity of MLTC and the resources that would be required to try and get a representative sample of all of these different condition clusters and combinations, we've tried to innovate and adopt the use of an AI-enabled approach, which I'll describe to you now. So before we started, in terms of the conditions that we wanted to focus on, it would obviously be unrealistic to think about and trying to capture every single condition or condition combination that people might have. So we looked to the literature and identified a list of 24 conditions that were highly prevalent in MLTC and used that as our basis. And this is the list here. From there, we went to single condition proms, but specifically single condition proms that had been developed and co-designed with people with lived experience. So that was one of our ways, our routes into capturing lived experience. We searched a database called eProvide that has over 8,000 PRO assessments within it to identify proms for each of those 24 conditions. We located 51 proms that were co-designed with people with lived experience, and from that identified 655 symptoms. We then looked to expand that list to thinking about inclusivity and representativeness by going to generative AI. We used the LLM, the large language model ChatGPT, and it prompted it to produce lists for each of those 24 conditions for 75 symptoms per condition. So we had 1,800 symptoms. We then merged in step 3, we merged those lists, we refined them, we reduced them, so we removed duplicates, we removed any questions or symptoms we thought were vague or not relevant to MLTC, and that was undertaken by a team at UOB comprising GPs, allied health professionals, and patient-reported outcome methodologists. So from our total symptom list of 2,202, we excluded just over 2,000 with a final list of 190 symptoms. We then sent those forward to a panel of healthcare professionals representing 11 different specialties, so 17 clinicians, and asked them to sort of assess it for face validity. Were those symptoms relevant in their clinical experience, to MLTC, to their specialty? Did they feel that was there anything missing? And from that, we developed a conceptual framework, so an overarching framework of what to measure that comprised 18 domains, 17 symptom domains, and 1 domain measuring so I say symptom domains, so body systems, and 1 domain measuring interference on daily life for 151 symptoms, representing those 24 conditions. So here is the initial conceptual framework, showing the different domains and the number of symptoms within each of those domains. But this is really just the beginning. So although we've used AI and existing prompts to develop this list, what we really need to do now is work with people with lived experience of MLT to refine and pilot test using interviews and surveys to check relevance across diverse experiences, to ensure comprehensiveness, to confirm ease of understanding, and then to field test to check if it works. And what we're doing at the moment is exploring whether some of these emerging methods with AI and large data sets can also support working with people with lived experience to ensure that the SPQ is inclusive and does capture MLTC complexity. So still some work to be done. So before I close, I just also wanted to highlight some of the work that's ongoing within the methodologies work stream for the CNC. So back in November, there was a work stream priority setting workshop specifically on the theme of methods for MLTC outcomes focused research. So a group of researchers, clinicians, people with lived experience met online. And that was led by my colleagues, Dr. Victoria Keevil, Professor Raphael Piera, myself, and Dr. Heather Walker. And the research question we were really asking is, what is needed? What research is needed to ensure that we have fit for purpose methods for MLTC outcomes research? So that work is currently being prepared for publication, but just to highlight some of the key messages, which really aligns with what I've been saying today, is that it's really important that we understand what outcomes matter most to people with MLTC and their carers. That we really need to make sure that the methods we have ensure that the outcomes and the outcome measures work for everyone, that they're inclusive, and that frameworks are needed to support standardization, to promote integration and use at scale. So thank you very much for your time today. To summarize, in this presentation, I covered what are PROs. So PROs focus on what matters most to people about their health, and PROMs are the tools that we use to measure PROs. Why are they important to MLTC? They support NICE recommended approaches to person-centered holistic MLTC care. And they also support triage, clinical conversations, monitoring, service development, and improve outcomes for patients. How do we measure PROs in MLTC? Well, it is challenging and due to complexity, and that we're going to need innovative methods to support inclusive PROM development. So leveraging AI and data science, developing cross-cutting tools rather than relying on multiple single disease measures, and to ensuring we maintain the voice of the person with lived experience at the forefront of our development. And that the SPQ is one example of a cross-cutting MLTC PROM. So in closing, in terms of a call to action, we always have to have one of those in a presentation. I'd really be grateful if you could consider how PROMs can support MLTC research and care. For those people who are living with MLTC, do consider involvement and or participation in MLTC research. And for researchers and clinicians, if you're selecting PROMs, to think carefully about measurement properties, burden, health inequalities, and how we can innovate to make sure going forward we have inclusive measures for MLTC. Thank you very much.
Thank you very much indeed, Sarah, for a fascinating talk and for sharing all of the amazing work that you're doing around, development of the SPQ and PROM development. We've already got some questions coming in. Should have said at the beginning, if possible, you can write the questions on the Q&A, but I am also monitoring the chat. So any questions that have already been posted there, I can also share. So I guess a really good question to start off with, Sarah, and we've got about 20 minutes, I think, for questions. So a question that came in quite early in your talk was thinking about whether PROs also include or incorporate the views of carers of someone living with MLTC. And I guess a sort of follow-up to that is sort of how do they do that, or what is the best way of trying to do that?
That's a really excellent question. And PROs, by their definition, are intended to be self-completed by the person because we're measuring things that are only known to them. However, there is a real role for what we would call carer-reported outcome measures because we appreciate for some conditions, understanding that carer perspective is particularly important. So yes, it's a PRO for carers. So whilst patient-reported outcomes really are about self-completion, And certainly regulators, things, people like the FDA really discourage what we call proxy measures. So reporting on behalf, so another filling in the prom for that person. But there is definitely a role for care measures going forward as a complement to PROs.
Well, thank you. It's really interesting. I guess another question, sort of on the completion of PROs, or I'd say now proms. Some question is sometimes proms are very long, and patients can feel quite bored or tired when they're completing them, and therefore they might not answer without paying enough attention or leave questions unanswered, which I guess reduces kind of the usefulness of the prom. So what can be done during the design of a prom to prevent this problem? And what have you done, I guess, Sarah, in your own work?
That's
Yeah.
a really good question. That's a really good
Mm.
question. And it's something that we um, were looking at a year or so ago in some consensus work that was led by my colleague, Professor Lee Agabusi at CPRO, looking at that issue of respondent burden in patient-reported outcomes. And there were some really interesting findings. I think there's often an assumption that shorter is better. But what we found in our work is that proms are not perceived to be burdensome, even if they are quite lengthy, if they are relevant, if they really resonate with the individual in terms of their lived experience. What we've been told by patients and our PPIE partners is that we're willing to complete these because they're important and they really reflect what's important to me. That said, if you then move that into a clinic situation, we have time pressures. So there may not be the luxury of having longer, more detailed PRO measures. And we do need to look at short forms. So that is one option to look at short forms that exist, which are developed off the basis of a longer measure. And we also, with the move from digital innovation and the Fit for the Future, the NHS priorities, we have the capability within digital administration to use things like logic to shorten measures and make it easier to complete. So, for example, I could give you an example for with our long COVID work, but I could probably talk at length for that. So hopefully that's enough of an answer for you.
Yeah, and yeah, that's thanks so much, Sarah. I guess kind of following up again on kind of prom development theme. So somebody, an anonymous attendee, has asked sort of why would individualized or personalized measures that allow respondents to weight different domains or place domains in order of importance be useful in MLTC research? I guess it could also be in clinical practice as well. But almost asking, instead of asking about specific pre-specified domains, asking the patient to weight the domains by order of perceived importance to them.
Yeah, so individualized prompts where people will state what's important to them whilst they complete the measure are established. And certainly, in my clinical field of hearing loss, we have something called the IMPOS, or the Individual Management Plan outcome score, where those needs are articulated by the individual, and those can be very useful. The development differs slightly than the traditional path. And so, yeah, there is a role for them. I guess what we need to balance and weigh up is, are these prompts also going to be used? Is how they're going to be used. Are they going to be used just at the individual level where these are probably most appropriate, or are you also going to want to use them to do sort of service level management or for research where you need aggregate scores? You need to be able to group the data together, where it becomes really difficult if you've got different questions for each person. So I think there's a role for both.
Yeah. And sort of just going back to it's a follow-up question on one of the earlier questions, but where we talked about carer reported outcomes. And somebody has asked, sort of, while I appreciate, the answer, for specifically underserved groups or sort of cultural competence, they've written inherent mistrust in research for certain groups. There could be a role for carers or a healthcare advocate or a trusted voice. And perhaps that's something that we also need to think about addressing. So I guess that's sort of more of a comment, but I guess how do we ensure that those underrepresented groups, perhaps who have mistrust in the health profession and or aren't able to sort of complete the prom for any reason, how do we engage those people and ensure that their voices are heard as well in research and in clinical care?
Yeah,
Yeah.
no, that's a really, really important question. And I think this speaks to not only PROs, but research more widely. Certainly engagement in the development process early on, building relationships with communities, going to communities to understand what is needed to support PRO development and PRO completion. It's very much about that co-design, and working with communities in a way to build trust, I think is critical.
Yeah. And I guess sort of related question perhaps, but how well does the symptom domains allow for different interpretation of symptoms by people from more diverse cultural backgrounds? So how well, it says here, how well do they reflect symptoms experienced by people outside of the kind of AI echo chamber of research?
Yeah, no, that's a really good point. And so I think this speaks to again the development process. One of the key steps is to ensure that questions are answered in the same way by different groups or different subgroups. So be that um, gender or ethnicity or different cultural groups or age, any of those sort of demographic characteristics, recognizing that health is very much a cultural concept. So we do, as part of our evaluation of measurement characteristics, we look at something called measurement invariance. So we want to make sure that those items are being understood and responded to um, in a way that's equitable across these different groups. And it also speaks to having that really close relationship when we're first starting to develop those questions so that we understand those questions are relevant to multiple groups.
Yeah, thank you, Sarah. And I guess this is another question coming in, sort of quite MLTC specific, which I guess also speaks to how we define MLTC. So it's talking about for kind of conditions like, they give an example of chronic kidney disease in its early stages, which would, count as a condition as part of an MLTC, or hypertension, for example. How do we kind of address those conditions that don't have symptoms and patient awareness? So obviously a lot of the patient-reported outcomes we talked about are to do with that person's experience of the illness and their symptoms, but what about those that are kind of, I guess,
Yeah.
picked up in a clinic but don't actually necessarily have symptoms?
Yeah, so I think this speaks to, and I think hypertension is a good example. Um, if or as you say, CKD in its early stages where it may be asymptomatic, um, this is where it's not it's not clinical measures or proms. It's they're meant to support one another. So it may be in some cases, such as hypertension, those measurements of blood pressure are really important because PROs are, there are no symptoms that are patient reportable. We need to rely on clinical signs.
Yeah, I think that's really important. And another question, sort of thinking about the order of questionnaires of symptoms. So this might be particularly for in settings where people are asked to fill out multiple different questionnaires.
Mhm.
Do you think the order of those has an effect on the answers that we receive? And is there any guidance that you're aware of, Sarah, about how we order questionnaires? And I think they've given a very good example here, which is sort of a quality of life questionnaire asked before or after the PHQ-9, which is widely used in primary care for depression screening. Whether that's asked before the questions about depression or after the questions about depression could obviously have an impact on the responses.
Yeah,
How can we
so
approach
there's I think there's two parts to that question. So the first there's the ordering of questions within a questionnaire, and we know some questions can be, I'm thinking now, and I'll think about prompt development, and then I'll come about implementation afterwards. If we talk about the development, when we're actually structuring and building those questionnaires, we have to be very mindful of things about potentially sensitive questions, questions that might be associated with social desirability bias. So, for example, I've had experiences when I've been pre-testing a questionnaire where the participant has said, I wouldn't complete this with my spouse in the room, my partner in the room. It's too sensitive. This is too personal to me. So we think very carefully about how we order those questions. And there is guidance out there in terms of survey development of how we position those questions within a prom. In terms of administration of proms within the context of a clinical consultation, I'm less, that's something I'd have to go away and think about. It's very much about implementation rather than development. And I think, and I'm not actually aware of a body of research. That doesn't mean it's not out there. It's just that I'm not aware of it in terms of looking at the delivery of questionnaires in the context of a clinical consultation, or again in terms of research as well. I know within some of the work I'm doing in Birmingham with another group looking at cellular therapies for cancer, we've had long discussions about when should these questionnaires be given? What order should they be given? And I think it's very much a process of co-design and really thinking about clinical practice and your pathways and talking to patients.
Yeah. Thank you. And another good question from Edward in the chat, which I think obviously speaks to your experience, Sarah, as a clinical experience as a speech and language therapist, is how do we engage the multidisciplinary team in the prom cycle, which obviously you talked about in your talk,
Mhm.
to ensure that we, optimize outcomes. And in your own work, was there a role of a Delphi or an e-Delphi in development of
Yeah,
that
yeah,
SBQ?
certainly. So yes, so we've done both. We've sort of had expert panels. We've had eDelphi to look at question relevance, question comprehensiveness from a clinical perspective, getting views early on from healthcare professionals and researchers about the clinical utility of these questions is very much part of that early development work in the cycle. And I think it's just also because questions are important, but questions also have to be useful as well in terms of their clinical utility. So is balancing that patient voice, but also thinking about what it means in practice. So in that very early stage, there's also work to be done with healthcare professionals, researchers in terms of establishing that content validity.
Thanks, Sarah. And I guess thinking again about sort of prom validation now. So Kieran's asked, sort of proms are validated at the level of the study population. I think this probably doesn't just apply to proms, but lots of other measures as well. But does that mean that there's kind of question marks over their use in individual patient care? So a measure might give you a good idea of quality of life when you apply it to a whole population, but it might not be, that good for that specific individual in front of you. So I guess it speaks to sort of how we apply these perhaps as part of our clinical care.
Yeah, no, that's a really good question. And it speaks again to how proms are developed. So when we think about developing proms, there are really two sort of psychometric or measurement models that are used. One is sort of a traditional called classical test theory, and that very much looks at the prom at population level. In terms of the way the validation, the evaluation of its measurement characteristics is undertaken. Um, so the other part is modern measurement theory. So things like item response theory, rationalysis, which allows us then to validate the prom for use at an individual level. So it's really, again, when you're thinking about PRO selection or when you're thinking about developing a prom, how do you want it to be used? Because there are a lot of proms out there, particularly older proms that have been probably developed using classical test theory only, increasingly now using modern measurement techniques. So we need to think very carefully, if you want to be a purist about it, I mean, I'm all for pragmatism as well, but if you want to be the purist, you should be using for individual patient care proms that have been validated using modern measurement techniques.
Great. And a slightly challenging one that I've just looked up to check that I understood it correctly, was how do we try to make sure that proms don't fall prey to Goodhart's law? Now, Goodhart's law, I've just looked up, states that when a measure becomes a target, it ceases to be a good measure. So how do we ensure that, proms don't become targets and then they're no longer, useful for measuring what we want to measure in clinical practice? And you can have to think about that one, Sarah, because it took
Yeah,
me a while to get my head around the
I
question.
think I'm
Thank
going to
you.
some
Thank you to
time to think
Anonymous for
about that
asking that
one.
one.
Uh,
Yes. So how do we make sure proms don't fall prey to, becoming a target and then ceasing to be a good measure anymore?
so I think this is a differentiation. If I've understood the question correctly, and I invite the attendee to please, into this as well and add further information. It's about differentiating the PRO from the tool itself. So, what is the construct of interest that's being measured versus how we're measuring it? And when we're developing a measure, we should have representative populations to complete it when we're looking at their measurement characteristics. So we have people with, high levels versus low levels of a particular burden, for example, so that the measure it's not the measure that's the target, it's the construct that's the target. I think it's maintaining clear separation. I'm not sure I've answered your question, but happy to take this offline, so please get in touch.
Yeah, nice challenging ones for the end, Sarah. So,
Absolutely.
yeah, we've got just a few more minutes. So, if anybody else has a question they're burning to ask, please post it now in the Q&A, and we can perhaps take one or two more questions. But while you're thinking about your burning questions, there's just a couple of comments that I thought would be useful to highlight. So, Russell Cowper in the chat has said, "Would it be worth asking the James Lind Alliance to do a priority setting partnership to find out what research priorities are required by patients with MLTC, and that could possibly guide future problems?" Um, and Joe Butterworth has answered to say that the JLA from the MLTC Models of Care workstream is likely to address this. Survey round one has just opened. Dissemination will be happening this week and next. Please watch out. And they want to reach diverse public and carers as well as diverse practitioners in health and social care as well. So
Brilliant.
I don't know if there's anything to add to that, but I think thank you very much, Joe. And I think Swati wants to ask a question, which is fine. Yes, yep. Can you, yep, if you're able to unmute and ask a question directly. And I've seen your comment as well about supporting the work stream on models of care, which I was just about to read out, but I'll let you speak about that yourself, Swati.
Is that working?
Yes, perfect. Yep.
Brilliant. I feel like I've been put on the spot. Sorry.
Yeah, no, it's right.
Asked so many questions. Thank you for reading them all out.
That's all right. Thanks for your great questions.
I
Yeah.
guess the question I think that you're referring to, or what I was offering, is that what this you're alluding to?
Yes, yeah. So you talked about please let me know in a personal capacity,
Yeah, so
yeah.
I'm a carer, which is why I've asked all the carer related questions of someone living with MLTC. And I know that you would get very different answers if you ask my dad to complete a PROMS compared to if you ask me. But I also have health literacy because I'm a clinician. So a double-edged sword.
Mm.
But I'd be more than happy to support any work because I'm already working with Jo Butterworth and her team around the models of care, either in a personal capacity or in my role in the Kidney Research UK as the multiple long-term conditions lead. So if there was a desire to involve the third sector in this work, then please do let me know and I can share my email after the event.
Oh, thank you, Swati. That's wonderful news. We'd be very keen to sort of take this conversation further. So please, I do email me. I'm not sure if we can put my email in the chat or something like that, because I know it was on my last slide. Perhaps I can reshare it. But yes, please do reach out. Be keen to talk.
That's great. Thank you, Sarah. And I guess just got 1 minute to go. I guess there was another question from an anonymous attendee, which was asking how can we help you validate the SPQ? And And then also, is there going to be a fee for using this measure? But I guess perhaps in just the last minute or so, Sarah, if so I know you've just submitted it for publication, so it's sort of hot off the press, but
We've
sort of what?
submitted the first bit for publication, so
Okay, the first bit.
so
Okay,
yeah,
so
anyone
lots
who's
still to do.
interested, we'd be grateful to have a further conversation to see how we could collaborate. So if I could put my email in the chat, that's probably the easiest thing to do if I can find it. Then, or perhaps Will can do that because I don't think I
Yeah.
can do that. It's s.e.hughes@bham.ac.uk. Yeah, we'd be really grateful to have a further conversation because it's complex and there's lots still to do. But
Yeah.
thank you very much.
And I think a lot of people on this call might be very interested in trying to help, validate that measure in practice and in research as well, Sarah. So
Yeah.
hopefully you can find some collaborators from the call today. I think hopefully we've answered most of your questions today. Thank you so much for all of the fantastic questions, and obviously for your great responses as well, Sarah. I think it's been a really, really fascinating webinar. I've certainly learned a lot, which I think I can apply both in my clinical practice as a geriatrician, but also in my ongoing MLTC research and work as part of the methodologies work stream. So I think I'd like to thank everybody very much for taking this hour to join us today and for all of your engagement and great questions as part of this webinar. And yeah, look forward to your ongoing work, Sarah, and what's to come in the future. So thank you very much, everybody. And Sarah's email is in the chat if anybody would like to follow up after this webinar. Thank you.
Thanks.